Welcome to our webinar series for professionals.
So welcome everybody out there to this webinar, because I feel it's something we can action upon quickly. I mean, we've got Tom here. He's going to talk about new markers related to the GI effects test. And quickly we can put a webinar on stage, and you can all sign up and we can have a lovely hour here together where we're just going to learn about biochemistry in the gut, and gut relates to the bodily systems as well. So that's what we're going to do today. I'm just going to let you all know that we have an event, a webinar as well. Next one coming up is on hair testing, hair mineral testing. So, but invites are already being sent out now for that, so that you can sign up for that. That was request from practitioners. So if you have wishes and requests, let us know, because we can't guess what you need. So by all means, share your thoughts and ideas and needs with us so that we can improve constantly. We always want to be better tomorrow and next year and what have you. So, but this is being better in regards to GI map. It's markers that I have asked for to Tony, the founder of the GI, or the creator of the GI map test. And so it's really nice to get, for sure, short chain fatty acids onto a profile, because that's markers I've been used to working with, and suddenly I felt they were kind of missing in GI map, like an arm was missing. But it's for sure new to me to work with the bile salt markers, so I'm really excited. So everyone, Fabian will take over now. He's an expert in regards to GI map. He's been educating us several times here, and it's always a pleasure to have you educating us, Tom. So unmute yourself and share your screen with us, and yeah.
All right, well, thanks everyone for taking time out of your day to learn a little bit more about this new add-on test for GMAP. I think it's actually a big deal in terms of the information that you can get out of it. It really helps expand the clinical utility of GMAP. So we're going to get into those details here momentarily. So those of you who are not so familiar with the new test, let's just dive right into what this new test is. Again, this is an add-on for GMAP. The name is StoolOMX, and it refers to the fact that it covers stool metabolomics. So it includes metabolites that are produced by the microbiome, two major categories of metabolites, and those are bile acids, which is really an exciting field right now. If you look at the research on bile acids, there's new research coming out in the top journals virtually every day or every week on the relationship of different bile acids to different aspects of health. So I think it's really important to learn about those. Certainly goes way beyond just the traditional view of bile acids as being necessary for proper fat digestion. And that is, of course, it's one of its primary physiological roles, but now we're learning so much more about how bile acids and the ones that are converted by the microbiome into secondary bile acids have so many health impacts, both positive and negative, depending on the context. And then, of course, there are the short chain fatty acids, which covers the usual ones that I think many of you may have heard of or may actually have worked with in the past. Of course, things like butyrate, acetate, but it also includes a variety of branched chain fatty acids, which gives us a window into the other sort of mirror side of fermentation. We will cover that and how that's related, in particular to gut motility. And there's potentially some downsides to some of those branched chain fatty acids and what they signify. So I think it gives us a nice overall picture that goes significantly beyond what the GMAP covers. So as I mentioned, more complete picture of gut health, and definitely key clinical insights into the following in particular. So we get further insights into microbiome balance, especially when it comes to the commensal bacteria. So of course on GMAP we have a commensal section That covers primarily just keystone species and groups, and also the high-level picture from the phyla. But of course, we don't cover the entire microbiome. But when you look at the metabolites, that's really the sum total of the activity of the commensal microbes. So we're getting a much bigger window into the overall activity of these. And that's really what's important. We do want to know what microbes are there, but we also want to know what are they doing, what are they producing, and how can that fit into the clinical picture. Certainly, these are now known to be really important for metabolic health. Both short-chain fatty acids and certain bile acids actually can help regulate GLP-1, for example, and other gut hormones that influence metabolic health. Intestinal barrier health is another key aspect. So we're always thinking of leaky gut, markers for leaky gut like zonulin, but it actually goes much beyond that in terms of the sort of more systems view, the holistic view of the intestinal barrier, which includes the mucus layer, includes the health of the epithelial cells, the immune cells in the mucosa, et cetera. So these short-chain fatty acids and bile acids are now known to actually play major roles in regulating many of those different components of the intestinal barrier. And we'll talk just a little bit about that. Immune balance is another key aspect of the effects of these different metabolites. So we're learning a lot more about which ones may actually promote immune balance and anti-inflammatory functions, and then which ones, whether they're deficient or in excess, might actually play a role in inflammation. So really important insights there as well. So again, it extends a lot of what we see on GI map, where there are already markers for leaky gut and markers for immune balance. We're getting additional insights into key players in that balance. And then gut motility issues, which is probably one of the most important set of insights that we can get related to bile acids and short-chain fatty acids. Both of these types of metabolites are well known and well established to regulate gastrointestinal motility. So in general, when they're deficient or in excess, that can influence the balance, that can sort of play a big role in whether patients are more prone to constipation versus loose stools or diarrhea. So again, really important information to know and to learn how to connect those dots. So that's really a big part of what we're going to focus on, is connecting the dots. So just to give you an idea of what the report includes, it's a 3-page report that gets added on to GI map. You can see here, it starts with a summary page, which is really the sections that you're going to rely on the most. The other pages, the following 2 pages in the report, give you a lot of details on the individual metabolites, so you can drill down into that information if you'd like. But a lot of people, who are busy seeing a lot of patients and clients, you're already taking time to review a lot of tests and GI map. So the summary page is really going to be your tool that you're going to use mostly to really get kind of the high-level picture of what the balance is in these products. And again, the point of this webinar is to help start connect those dots for you and to what that means when you see imbalances. So for the short-chain fatty acids, there's a summary section here of the major ones. The overall levels that are measured, and those are measured in absolute terms, so it's micrograms per gram of stool. That really gives you great insights into just how much is being produced. There's also how much is being absorbed as well. We'll talk more about that too, because there's multiple factors that affect the levels that are in the stool. And then we break it down by percent, so you understand the composition. We know what the general normal ranges are in a relatively healthy gut. So if even if the levels are normal overall, you might see that the composition is off, and that you might have, for example, low butyrate, high acetate, which is telling us there are microbiome imbalances that need to be worked on. So definitely you want to combine that information to get a clear insight into what that imbalance is. Then there's a more visual representation below. So it's kind of a quick way to compare the patient's results, which are on the left, versus the standard reference ranges, which are on the right. And those numbers that are around the reference are just the median values. And obviously there's some standard deviation around that that are still within the normal range, and that's really what these gradients above are showing in the green section when they're in the normal range. But the idea is you're kind of quickly visually comparing. Does the breakdown look about the same as the reference? To give you an idea, does it look pretty normal or does it look pretty imbalanced? And then the last indicator here is the balance between the short chain fatty acids and the branched chain fatty acids. So that tells us about carbohydrate fermentation in the gut versus protein fermentation. That's a really important balance to understand, particularly from a motility standpoint, but also for other health impacts. So a lot of summary information here that once you learn how to interpret it, can give you a lot of great additional insights. We have a similar section for bile acids. So you can see here in the first section, a similar breakdown, total bile acids in terms of the absolute levels in nanograms per gram, and then the percent breakdown of secondary versus primary. Primary are the ones coming from the liver. Secondary are the ones that are being converted by the microbiome into different derivatives of bile acids that have various biological functions. We also have a visual representation of the breakdown of the major bile acids. These are primarily secondary bile acids, since in a healthy gut, the vast majority of bile acids should be converted by the microbiome because that means you have good diversity in the microbiome. So they're able to actually carry out those changes in the bile acids and create these secondary bile acids. So similar scenario where you're just looking to see visually, does it look similar to the reference or does it look really skewed and way off from the reference? And then we also have this ratio here of two of the major secondary bile acids, LCA to DCA. So that can give you some further insights into potential microbiome imbalances that may have some clinical impacts. For example, lithocholic acid is has some positive and negative associations. So from a positive standpoint, it's been shown to promote metabolic health. And we'll actually see an example of that. It can promote normal motility, but also in excess, it's been linked to things like colon cancer. So this can give you some insights into whether the balance is significantly off, and then whether that relates to a patient's symptoms. Then we're just going to kind of quickly go through this, but if you want to dive into the details, we have all of the bile acids and other metabolites listed. So these are the bile acids in the primary bile acids section. You can see that highlighted here. This patient obviously had, excuse me, overall high levels. So this is a pretty imbalanced microbiome. Likely this patient has looser stools, probably less diverse microbiome, not able to convert them so well. This is the long list of secondary bile acids. So overwhelming at first, and again, a lot of practitioners probably not going to pay a lot of attention to this initially until you learn more over time. So there is that, that option for you to dig in further, because some of these bile acids have really good research on them in terms of their links, especially to metabolic health. So whether they're high or low, those may give you some additional clues as to what's going on for patients. But overall, we're also just looking for imbalances here. So even if you don't necessarily take the time to understand the individual information here, and we do have references available. And Catherine, you and I can talk about whether there's any additional references that you need or materials for education on this. But again, mostly when you're looking at this, you're looking for just general imbalances to tell us, do we need to work on the microbiome balance and the things that are causing microbiome imbalances? That's the secondary bile acid section. Same thing for short chain fatty acids. We have the ones that are generated from carbohydrate, meaning fiber breakdown. Those are the saccharolytic straight chain fatty acids. Those are the ones we're more familiar with in general. And then also the proteolytic ones. So those reflect more protein fermentation. And again, we'll learn more about that context as we go through the rest of the webinar. So when we're trying to understand the primary health effects of these two main categories of microbial metabolites, these are really the ones, and we're just reiterating from what we went through before: gut motility, intestinal barrier health, immune responses, metabolic health, and microbiome balance. So we're going to go through each of these categories and just illustrate what the research is around this, and then what we want to look for in terms of the results. Let's start with gut motility. That's one of the areas that's really best defined in terms of the actions of these microbial metabolites. So a few key points here. The overall balance of these metabolites is really key. So again, don't get too lost in the weeds or the details. Ultimately, when you're a busy practitioner, you just want to really identify, are there imbalances, and then how do I address those imbalances? So it's an additional way to identify microbiome imbalances. The best evidence overall in terms of roles for motility are for the short-chain fatty acids, bile acids, certain amino acid metabolites. That gets into a little bit of this protein fermentation. So a little bit of that is good, because we need some of these metabolites to promote motility, to promote immune balance, etc. You just don't want excessive levels. And then there's, of course, the well-known cell wall components, particularly LPS or lipopolysaccharide, that we mostly associate with inflammation. But there are effects of these cell wall components from gram-negative and gram-positive bacteria on motility. And there are specific receptors in the gut that they bind to that can actually affect motility. So again, if you see an excess of these inflammatory type species, for example, on GMAP, and that's consistent with patients having altered motility, that may be a target for treatment. There are a range of other microbial metabolites with varying levels of evidence. There's a class called biogenic amines. By far the most well-known would be serotonin and histamine. Serotonin is mostly produced by the gut cells themselves, our own cells, but there are some microbes that produce it. And then a lot of these other products like short-chain fatty acids and bile acids influence our serotonin levels in the gut. So serotonin, of course, is a major neurotransmitter that's involved in motility and other functions. Histamine, actually, which can be produced by certain bacteria, certain immune cells, also obviously in the diet as well, that can affect motility, and then others as well. And then lastly, of course, a lot of us have heard of the intestinal gases, hydrogen, methane, and hydrogen sulfide, that may also play roles in motility. The evidence there, I think, is surprising for people if you look at the research, that it's mostly based on correlations. There's not much evidence yet from studies showing directly that they cause changes in motility. They might actually just be markers for motility. So there's still some ongoing research there to determine how, if they do affect motility, how do they affect motility. But at the very least, we know they're markers. For example, methane, of course, is a marker for constipation. But again, the best evidence in terms of research is really for the short chains and the bile acids and a couple of these other categories. All right, so this is a great review article covering some of these aspects here of what we know about microbial metabolites and their role in influencing GI motility. This is a quote that kind of summarizes some of the key points here, that we know that the gut bacteria regulate GI motility through their cell wall components and metabolic products, which we just talked about. And then they go on to say the main groups of bacterial metabolites, including bile acids, short-chain fatty acids, tryptophan, and other amino acid metabolites, have been the best studied so far. But there are others, as they mentioned, that can influence motility. To start getting into specifics here about how we link imbalances to motility differences. So you can see here in this quote, they say that long colonic transit time, which is characteristic of constipation, has been associated with reduced fecal short-chain fatty acids. And that has to do with the fact that short-chain fatty acids are actively absorbed by the mucosa in the colon. Of course, they're used by the colon cells for energy But then they also get into the bloodstream where they can have systemic effects. So keep in mind that by the time the contents are in the form of stool, a lot of those short-chain fatty acids have already been absorbed. So that's why in constipation, you tend to see relatively low levels. And that may actually feed back then in further reducing motility, since short-chain fatty acids play a role in promoting motility. So it's a little bit of a vicious cycle. Then at the other end of the spectrum, you can see from the highlighted part lower that increased levels of short-chain fatty acids are detected in looser stools, and that reflects generally shorter colonic transit. So you may see higher levels in general in patients with loose stools and diarrhea. Now these are general trends. As always, there are exceptions. So you may not necessarily always see these trends in patients that have those issues with constipation or diarrhea. But if you do see it, that's likely telling you that these short-chain fatty acids are playing a role. They go on to say that reduction in short-chain fatty acid producers is consistent with a switch away from what's called saccharolytic fermentation. So that's the carbohydrate fermentation from fiber toward this proteolytic fermentation. So that's really where we're looking at the balance on StoolOMX to get further insights there and see what's going on with the microbial metabolites. But they emphasize this point here that once you have reduced short-chain fatty acid production, that's known to actually weaken the smooth muscle contractions that drive peristalsis. So that can play a causal role in constipation and slow motility. So working on ways to, of course, increase short-chain fatty acids in that scenario likely would be helpful. And this is an example of a patient that had relatively low levels and slower transit. So this is, even though their breakdown of the acetate, butyrate, et cetera, was pretty normal, their overall levels were pretty low, kind of on the low normal side of things. So that's consistent with a possible role in their slower transit. By contrast, this patient had loose stools. So you can see here that the overall levels are actually quite high, even though, again, the composition was pretty normal. So it's mostly just sort of a production sort of scenario here and possibly absorption from the fast transit, yielding those high levels of short-chain fatty acids. So this is a nice little schematic from a recent review article that kind of captures some of these basic concepts. So you can see that the colonic transit time is illustrated across the top, with the left being faster and the right being slower. So with faster transit, that basically is synonymous with the saccharolytic fermentation that results in short-chain fatty acids. And then with slower transit, again, this emphasizes the protein fermentation. And these products that you can see here under the protein fermentation, there's things like hydrogen sulfide, ammonia. So there can be some pretty negative effects to having too much protein fermentation. So by looking at those branched chain fatty acid levels, that gives you some insights into just how bad that situation is. And we have well-established ways to reduce that with fiber and polyphenols. So that can indicate a need there for increased intake of fiber and polyphenols. And again, this is just a screenshot from the short-chain fatty acids section illustrating that we can see these saccharolytic and proteolytic fatty acids to understand that balance. And then we also have a ratio here of the short-chain fatty acids to branched chain. So that can be a quick way to see, is there an imbalance in that ratio, either high or low. If it's low, that's usually consistent with slow transit. If it's high, that's usually consistent with diarrhea. But there may be other things going on, like inflammation, that can affect that. So quick summary here. These short-chain fatty acids influence motility by stimulating mucosal production of gut hormones and serotonin. Normally, most of them are absorbed in a healthy gut, and only about 5% are present in stool. They're higher if you have diarrhea, typically, lower if you have constipation. So just keep in mind this, when you're interpreting, you need to consider both production, meaning fermentation. So you're looking at the commensals to get a sense of that. And then also absorption. And so you're considering transit time in terms of absorption, but also inflammation. So inflammation can decrease absorption as well. So this is reiterating the trends that generally you'll see low short-chain fatty acids that reflect either reduced production or increased absorption, so slow transit. High total short-chain fatty acids reflect either increased production or reduced absorption. So again, you'll see that in a lot of patients that have motility issues, but there are exceptions. And sometimes, I've seen a few of those cases already. Sometimes it can be a little bit of a head scratcher to figure out why do they not have the normal pattern. But that's true of almost any sort of testing that we work with, that there are people that don't follow the usual expected patterns. All right, so a little bit about bile acids in transit here. So in this article, they basically found through various experiments kind of the same relationship with bile acids. At low levels were correlated with slower colonic transit. High levels were correlated with faster colonic transit. So if it's extreme, that's now known to be a key factor in what's called bile acid malabsorption, which can lead to bile acid diarrhea. And that's now thought to be a major contributor to a subset of patients with irritable bowel syndrome. And we'll see the stats there momentarily. But just kind of a quick insight into how these bile acids are known to function, summarized here in this first highlighted section, that they basically have a pro-motility effect, prokinetic effect. So in the IBS and SIBO fields, there's a lot of talk about using prokinetics for patients, obviously primarily with constipation. But we have natural prokinetics that are normally there, short-chain fatty acids and bile acids, to promote normal motility. So that can be a good starting point for a lot of practitioners before having to turn to sort of ways to force motility. And then there's also effects on fluid and electrolyte secretion. So that's another way in which they can help promote regularity by acting as stool softeners. And that's, again, when they're in balance, that's just normally what they do to promote normal bowel functions. This is an example of a patient that had really high bile acids, so basically indicating likely bile acid malabsorption. This patient's more likely to have loose stools. The primary bile acids also is another well-known indicator. When it's elevated, that can be consistent also with bile acid malabsorption. So this gives you clues for some patients that have loose stools. This might actually be a major contributor to their scenario. This is just a sample reference illustrating that they now think that this scenario, bile acid malabsorption, accounts for about 30% of patients with IBS-D, or diarrhea dominant IBS. So definitely something to consider when patients have IBS, that this can be one of the differential diagnoses that you're looking at to get a clue, is this part of their root cause? Just a little bit of a more deep dive here. There's some really interesting research around this scenario now. Recently, they found that mucosal biofilms are pretty common in IBS in a subset of patients with IBD. And that was associated with bile acid malabsorption, as we'll see here momentarily. So they say basically that they found that these previously unrecognized endoscopically visible biofilms, they were kind of ignored in the past. They were just thought to be due to improper colon cleansing before the procedure. Now they know that they're actually likely to be highly relevant. They're just biofilms that are attached, mostly in the ileum and the right colon in IBS. So that's kind of right where they affect a little bit of the small intestine and the large intestine. And they saw that in 2/3 of patients with IBS, and then 1/3 with ulcerative colitis. And that they also noted high E. coli. So E. coli seemed to be a key feature of these biofilms, so it might be playing a big role. And we actually see that association on GI map, and you'll see it as well, particularly in patients that have increased bile acids and an increased percent primary bile acids. This is just a visual depiction of what they saw. The top just shows the healthy scenario with good diversity, no biofilm, good levels of Faecalibacterium. Below there are these biofilms that where the microbiome was characterized as having low diversity, reduced Faecalibacterium, and increased E. coli. That's a really common signature in people that have diarrhea, whether it's IBS or even inflammatory bowel disease. We see this a lot. And I've even seen that imbalance in some patients with gut infections, such as norovirus, which is usually more of a temporary scenario. And the primary bile acids tend to be increased there. So it's possible. We know that bile acids are supposed to be reabsorbed in the ileum in a normally healthy gut, so they can be reused. That's part of that enterohepatic circulation. And only in a healthy gut, only a small percent get into the colon. But with all this biofilm in the ileum, that's likely interfering with that reabsorption. And that could be actually a cause. They still have to do more research, but they think it could be a cause of bile acid diarrhea. So that really draws your attention to E. coli and other related inflammatory bacteria as targets that you may want to consider when patients have these conditions. Just a few things here in terms of just some of the, I think a lot of us are very familiar with antimicrobial herbal protocols for addressing dysbiosis, even addressing biofilms and different ways to address biofilms. Because this seems to be a key feature with bile acid malabsorption, I just wanted to highlight a little bit of the additional research here. So we have studies now that indicate further benefits of vitamin D in combination with vitamin K as possible inhibitors of biofilm that are produced by these gram-negative bacteria. So again, in patients that are deficient, which a lot of people are, that certainly could be helpful. N-acetylcysteine, or NAC, also known to be a factor that can disrupt biofilms. Newer research also shows that it acts directly on the intestinal barrier through the cells in the mucosa to improve the intestinal barrier health, which they also showed help reduce pathogens and opportunists. So this could be a key factor to consider including in your gut health protocols for patients that have these sorts of scenarios. Lastly, there's actually some really interesting research on cinnamon and cinnamon extracts. They think the active ingredient, or one of the key active ingredients in cinnamon, is this cinnamaldehyde. They found in various studies that it can counteract biofilm and potentially can reduce E. coli, again, which seems to be a key feature of the biofilm. So different tools that we have at our disposal to address many of these imbalances. So now that was a little bit about bile acid excess that can cause bile acid diarrhea. But they also know that a deficiency of bile acids does seem to explain at least a subgroup of patients with IBS-C. So just be aware that that is also true on the low end as well, that there might be a link with IBS. So again, this is an example of a patient that had low bile acids with slower transit. So you'll often see that, even though the percents look okay, the breakdown looks okay, just the total that's really the problem here. They go on to say here in this article, just a quote that I pulled out here, that lower levels of bile acids also cause symptoms of constipation, longer transit time, and decreased colon muscle contraction. But they say furthermore, when butyrate and bile acids are supplemented, many of the constipation symptoms can reverse. So in practice, of course, it's very patient specific. Some respond to that approach, some not so much. Obviously, going to depend on what's going on with each patient, but be aware that these are some additional options for patients that have slow transit, especially if you see these patients with low short-chain fatty acids and low bile acids. All right, so quick summary here. Elevated levels of bile acids, both the total and the primary percent, can accelerate motility, while insufficient bile acids can slow motility. Bile acid malabsorption, usually due to reduced absorption in the ileum, sometimes due to overproduction by the liver. Some patients may have both. I've actually seen that in patients that have had their gallbladder removed. they can develop bile acid malabsorption just because their bile is not as regulated without the gallbladder. But that may be present in up to 30% of IBS-D cases, and also inflammatory bowel disease as well. It's also known from various studies that excess primary bile acids in the large intestine, in this scenario where you're getting some malabsorption, can actually promote this inflammatory dysbiosis. So it's a bit of a vicious cycle. They might both contribute or cause some of this, and then once they're malabsorbed, they can further exacerbate the dysbiosis. And that's been particularly noted in inflammatory bowel disease. All right, so a lot about gut motility there, but there are some studies that support some of these other functions as well, particularly intestinal barrier health and immune responses, which we're going to consider together because those often go hand in hand. This is a nice little diagram. Some of you may have actually seen it in previous presentations, because I really like how it just quickly summarizes how we go from fiber and healthy food components converted by the microbiome into short-chain fatty acids, and then just a few examples of their beneficial effects on the intestinal barrier. So we know they're super important for secretory IgA. So if you see low levels of short chains and low secretory IgA, likely we know that that's playing a role in causing low secretory IgA. Same with mucus production. We don't have direct markers for mucus, but we certainly have indirect markers based on mucus microbes like Akkermansia. So when those are low, likely mucus production is low as well, especially if you see that along with low secretory IgA. That gives you even more of a picture into the effects of these low short chains. And then tissue repair, that's a big aspect. When we're thinking of gut healing, it goes way beyond just leaky gut. The gut is constantly regenerating every 5 days or so. There's a whole new cell lining, and they play a role in that process. So they're really critical for proper gut healing as well. And then down below, there are some examples of how short-chain fatty acids promote immune balance by promoting anti-inflammatory functions. So lots of important roles there. There's more recent research about the role of bile acids, some of these secondary bile acids in particular that are produced by the microbiome that can promote this whole regeneration process. And that's what this title indicates here. Certain bile acids through a particular receptor can actually activate intestinal stem cells and promote this epithelial regeneration process. So they're part of the gut healing, natural gut healing process. So obviously they're deficient or in excess, that can throw that process off. Patients' guts may not heal very well if they don't have normal levels of bile acids. This is kind of an overwhelming figure here, but it's just showing us that they know a lot of these mechanisms for how bile acids basically have their functions, and it boils down to influencing these gut hormones, and then that promotes motility, but also promotes intestinal barrier function, as we'll see in the next example here. So we know that bile acids and short chains can promote gut hormones, particularly GLP-1. And one of the lesser known benefits of GLP-1 is it helps to promote intestinal integrity, intestinal lining integrity. So lots of ways in which these microbial metabolites can help promote gut health. A couple more examples here. So this is another study showing that a particular bile acid in the study was found to promote these T regulatory cells that have anti-inflammatory functions. And they showed that this particular one is called iso-allo-LCA. That's a secondary bile acid. Some of these are kind of a mouthful, so you don't really need to worry about learning these names, but just be aware there's an example here. Different research articles will refer to it as allo-iso or iso-allo, but it's basically the same thing, that can promote these anti-inflammatory cells. So among our long list of secondary bile acids, you can see that one listed here. This patient actually had high levels, so that's, may actually have some beneficial effects in this case, but it might also be a little bit excessive because there are scenarios where you don't want to have too much suppression of the immune system, particularly if you're dealing with gut infections, for example. or even a risk for colon cancer. Those are scenarios where you don't want to have too much suppression. So this could be good depending on the context, or it might be a risk factor if it's excessive. Just another example of recent study. This is a major study linking excess bile acids getting into the colon to an increase in these inflammatory bacteria. So they talk about Klebsiella pneumoniae and E. coli are frequently overrepresented in patients that have inflammatory bowel disease. Also, they mentioned Proteus, Mirabilis, all of those are on GMAP. They found an increased abundance of these bacteria that are generally referred to as Enterobacteriaceae. That's just a bacterial family that has a lot of these inflammatory species. But they found that these were increased in the colon in patients that had decreased reabsorption of bile acids in the ileum. So again, this is kind of a two-way street where these might contribute to that problem, but once the problem develops, that can further increase these inflammatory bacteria. So definitely can be a big problem for patients with inflammatory bowel disease. All right, so just a quick example here of one of the cases I reviewed recently. This is a female in her 60s that had a long history of Crohn's disease. And so you can see here that basically this patient had somewhat high total bile acids. Let me just highlight that section here. And so certainly that fits the picture. And also a very high percentage of primaries. We want to see that well below that cutoff of 7.8. And this patient was all the way up at almost 50%. So you can just see that visually from the fact that these indicators down below, obviously the patient's results don't even closely resemble the reference at all. So a very imbalanced scenario. Patient needs a lot of gut support in order to help try to mitigate some of that situation. This patient also had super high levels of inflammatory bacteria. A lot of these that were mentioned in the article: Klebsiella, Proteus, Escherichia, which is E. coli, and even Fusobacterium. So just a lot of inflammatory overgrowth. So this is where, of course, you're thinking, is it appropriate for this patient to have antimicrobial herbs? Do they have any upstream issues with digestion? Are there ways to address potential biofilms, et cetera? So there are ways potentially to help support these patients that may help to reduce this overgrowth. All right, so let's talk just briefly about metabolic health. We did have a recent webinar on that that was focused mostly on the metabolic health aspect. But here I just want to kind of summarize it, that we know that from the title here, short-chain fatty acids, secondary bile acids, and other products from the gut microbiome have effects on these enteroendocrine cells. Those are your gut hormone-producing cells that basically have roles in metabolic disease and can be therapeutic targets to improve. They mentioned this here: changes in the levels of short-chain fatty acids, indoles, and secondary bile acids are associated with metabolic diseases, and restoration of these levels may attenuate disease progression and severity. So again, underscoring why do we want to know about these imbalances, what specifically is imbalanced, and what are the ways that we can potentially correct those imbalances to help promote metabolic health. So that's really kind of the bottom line, but just a few more examples here. We know lots of research shows butyrate also has positive metabolic effects, helps protect against, for example, obesity and diabetes. We also know that the gut microbiome can regulate GLP-1 response through this bile acid receptor. So bile acids play a role there as well. Another example here, that bile acids can help regulate food intake, meaning satiety and hunger. And their dysregulation is noted in metabolic disease. So definitely something we want to pay attention to if patients have imbalances here and they have metabolic issues. A couple others here is a specific example of one of these secondary bile acids, iocolic acid. Actually, I think that's one of the minor primary bile acids. We'll see that in a second. But there's evidence for some of these very specific ones that they can actually bind to specific receptors, promote GLP-1 and other aspects of metabolic health. So it just gives us a lot of information to work with now when working with patients that have these conditions. This is just telling us where the hyocholic acid is on the test. So you can kind of pay attention to the overall balance, but then some of these you may want to note as well for specific conditions. Lastly, this is really interesting. One of the major secondary bile acids, lithocholic acid, was shown not yet in humans. This was an animal model, but it does seem to have some anti-aging effects that actually mimic the effects of caloric restriction. So again, speaks to the important role in metabolic health of these various products, and that's just from this quote here in terms of exactly what they found. But they said this LCA can recapitulate caloric restriction in mice. These effects include activation of AMPK. That's one of the well-known factors involved in metabolism. And they found that there are specific benefits in terms of enhancing muscle regeneration and also rejuvenation of grip strength and running capacity. So there's some exercise benefits as well. And just noting here where the lithocholic acid is, it's also noted on the summary page in terms of the balance between LCA and DCA. So in terms of just, there's lots of ways we can, of course, work to balance the microbiome. Within a metabolic context, of course, there are studies looking at how can we do this through focusing on different types of diets, Mediterranean diet, et cetera. And more specifically in terms of microbiome support. So there's growing research on fermentable carbohydrates like resistant starch. So that's basically what this study was about. And this was a clinical study, so it's not an animal model. It's actually in people. So they say here that the resistant starch supplemented group coupled with isoenergetic and balanced diets significantly reduced body weight and improved insulin sensitivity in humans. Mechanistically, the resistant starch induced changes in the gut microbiota, including altering bile acid metabolism, and then consequently reducing inflammation through gut barrier restoration. So all these effects that we just talked about for bile acids do seem to play real world roles in response to some of these therapeutic approaches. So again, resistant starch gives you another way to think about how do we support patients who have metabolic issues, but also have known bile acid metabolism imbalances based on the StoolOMX. All right, so a lot of information there. So just kind of want to recapitulate that we talked about these different categories now and gave some specific research examples and what you would potentially see on StoolOMX. Obviously, any of these categories could be a full webinar. And we do have a growing list of those as well on these different subjects, but this gives you a nice overview that there is good solid research in support of the effects of these different major components that are produced by the microbiome. So really that kind of illustrates how this adds a lot of clinical utility to GI-MAP. All right, so do we have time for a quick case example, or would you rather open it up to questions at this point?
We have time for a case. We love cases.
Okay, so this is a pretty quick case. This patient actually did have some other issues, but I wanted to keep it simple and boil it down to what was really probably the most relevant for interpreting the results. So this is a early 40-year-old male who basically had chronic loose stools, really unexplained, had been working with a practitioner for a while and couldn't really get to the bottom of it. So this helps illustrate how GI-MAP plus StoolOMX can provide additional insights into that scenario. So starting with H. pylori, it was elevated. So we're always thinking top to bottom in terms of that root cause scenario. So H. pylori might be one of the factors contributing because that can reduce stomach acid, which then can have effects on the microbiome, and also obviously reduced digestion does affect the functions of the GI tract. As far as the commensals, overall not bad. My understanding is that this individual is on a pretty healthy diet. Definitely low akkermansia, which suggests possible low mucus production. Plus, we know akkermansia is one of the microbes that has a big role in the intestinal barrier health and also in metabolic health. So there may be some downstream consequences there. But really not much going on with the commensals themselves. As far as the opportunistic microbes, though, we do see significant overgrowth in that top section. Many of these are known to chronically be elevated in patients that have poor digestion. So this adds to this reduced digestion and absorption scenario, particularly Enterococcus, Staphylococcus, and Streptococcus. Those are widely noted in many research studies to be linked or a consequence of low stomach acid. So we're thinking possible connections. H. pylori might be part of that, since H. pylori can suppress stomach acid. Morganella is also kind of more of a significant bad guy. That's an LPS producer. It can be inflammatory. It's also a major histamine producer. Histamine was one of those factors that we saw earlier on that can influence motility. So it actually might be one of the factors contributing to this patient's looser stools. So it's worth considering that, treatment with antimicrobials, which is pretty common for inflammatory species, might be a good approach to consider here, along with possibly supporting digestion. But we always like to look at the rest of the picture first, just to see what's going on, put the picture together. As far as inflammatory species, not a lot of overgrowth, although we do see a little bit of Citrobacter and Klebsiella detected, so that adds a little bit to this dysbiosis picture. In this section, this first inflammatory section, even when they're detected, that can still tell us a little bit about dysbiosis. So we don't want to ignore these completely if they're not high. No fungi, yeasts, no viruses, and no parasites, so all those look good. As far as the intestinal health section, just a few imbalances. So we see with digestion, fat malabsorption is fine based on the steatocrit. Elastase is suboptimal. So that adds to this overall reduced digestion picture for sure. Secretory IgA is really high, right? So this patient is reacting to something. The two main sort of factors that we know that tend to result in high secretory IgA usually are either some sort of gut infection, although we didn't see anything notable. And then the other one, which is more likely in this scenario, would be food reactions. And food reactions are now known to be another potential contributor to, of course, gut symptoms in general, but also to looser stools. So it may be worth considering whether this patient might benefit from an elimination diet. I also like to note the eosinophil activation protein. We may end up revising this reference range at some point, but generally in patients that don't seem to have any issues, it's way down, like below 0.1. If you see it around 1 or above, I see that tends to correlate with patients that have evidence of food reactions. So even though it's still in the green, it's kind of high normal, but I still note that one when it's above 1. Calprotectin looks good, so there's no evidence here of significant inflammation. And as we might expect, of course, zonulin is a little bit elevated here, so some intestinal barrier issues for sure. All right, so let me go ahead and look at the short-chain fatty acids section. So this patient does have pretty high levels of the overall short-chain fatty acids. So as we talked about earlier in the motility section, when you have fast transit, that allows less time for the short-chain fatty acids to be reabsorbed. So you're likely to see high levels. Because they can promote motility, that can be a vicious cycle. You have too many short-chain fatty acids. We think of them as beneficial, of course, but too much of anything can present some problems. So likely, if you kind of put the pieces together, if this patient's not digesting and absorbing very well, has some of those small intestinal microbes overgrown, small intestine might not be as healthy as it should be. This patient could be getting additional foods getting into the colon, stimulating increased fermentation, and that might be part of this process here. And then if you have too much of this, again, that might promote motility. But the composition actually looks pretty good. This percent valerate is a little bit high, but not that notable. But the main thing by far here is just the total. Seems to be quite high. The other ones actually look not too bad. Certainly now when we look at the bile acids, we're getting even more of a picture here that there's something going on in the small intestine likely. that may be preventing the reabsorption of these bile acids. So we have the total that's quite high, and then the percent primary that's quite high. So this is likely telling us that this patient has some level of bile acid malabsorption, which has been strongly linked to looser stools. So clinically, if you were to send this patient to a GI doctor, a gastroenterologist, if they were to confirm, they might run additional set of tests to confirm whether the patient has diagnosed bile acid malabsorption. Sometimes patients might have subclinical, so they might not meet the criteria for outright medical definition, but they might still be off balance, which is, of course, what we look at in functional medicine, is sort of more to that functional range. But in the medical setting, they might prescribe bile acid binders, for example, like cholestyramine and other bile acid binders. But now that we have all this additional information, working upstream on gut health, on digestion, working on the microbiome imbalances, all of those may also play a role in helping to reduce this scenario. So again, it really gives us some additional insights into what might be going on for this patient that has, up until now, had unexplained loose stools. Also note that this LCA-DCA ratio is off, and that mostly just speaks to the fact that the microbiome is imbalanced, which we already saw from the GI map results. All right, so quick summary. Again, this is a male, early 40s, chronic loose stools, high H. pylori, which suggests hypochlorhydria. So treating H. pylori is something that some practitioners would do here. Usually more, if it's not a serious infection, of course, they're going to more likely do an herbal protocol with some sort of mastic gum-based formula. Low akkermansia, which we have noted, and also in research, could be due to the fast transit. So that may not be something to worry so much about because it's a slow-growing species. When transit is too fast, it generally doesn't do very well. So that might just increase on its own as you're working on the gut. High staph, strep, and enterococcus commonly suggests hypochlorhydria, so it's consistent with H. pylori, but it's also consistent with generally poor digestion, including low pancreatic enzymes. So certainly digestive support is something to consider here. High Morganella, moderate Citrobacter, and Klebsiella, which suggests increased LPS and possibly histamine. Certainly both the LPS and histamine have been linked to altered transit. So addressing those bacteria with usually antimicrobial herbs are used a lot in our field. But also food reactions might also be part of the picture here, especially histamine-containing foods. Suboptimal elastase, again, digestive enzymes, pretty common. Working upstream on if this patient has stress, if they're just not eating properly, they eat too fast, all those things that we would normally suggest. With high secretory IgA, generally that's not treated directly. Usually you're looking for what's causing it. In this case, I would suspect food reactions. So certainly either doing a food sensitivity test or elimination diet might be helpful. But also addressing all of these other factors would likely help any sort of food reaction scenario. Certainly elevated zonulin is telling us there's a little bit of leaky gut. That could be related to those LPS producers. Histamine can also contribute to that. And then also the food reactions, if there are food reactions. So there's a lot of things that can increase leaky gut, even stress and poor sleep. So lots of things to consider there with leaky gut. And then the last two, high short chain fatty acids, usually due to fast transit or increased fermentation or both. Increased fermentation, again, could be due to poor digestion and absorption. And then that high total and primary percent bile acids suggests bile acid malabsorption. And then you're going to really want to focus in on those small intestinal imbalances. And also be aware that different fibers can act as bile acid binders. So psyllium, for example, is often used in patients that have loose stools, just to see if that works, and that may work by binding up some of the bile acids. Right, so a lot of information there, so I imagine you may have some questions, but thank you so much for taking the time to listen today and understand how this test can help you get additional clinical insights for your patients and clients.
And thank you, Tom, for presenting to us. It's so exciting, and it's really nice to dive deep into this area as well and getting clues to how else to interpret the results. So yes, questions came up. So a practical thing, when you are in VMS, your practitioner portal, and you order a GI map or a GI map with sonulin, because those are the two GI map tests we have right now, then a pop-up appears and it says, would you like to add OMX? And also gluten peptides actually comes up as well. So just that's a practical thing. So then moving into some of the questions here. So there's a question, because sometimes patients already are on bile binders like Cistran. And so more should we practitioners, if someone is on Cistran, isn't that what it's called in America as well, Cistran? This it's also a cholesterol binding medication, but it's more like, should we tell them not to take it, and for how long time should they not take it, or should they take it and they just collect on a random day?
We don't have specific recommendations for what patients should or should not stop in terms of treatment. Obviously, that's something they have to discuss with their practitioner, because in some cases they really may depend on the treatment heavily. And to reduce its effects on the test, they may have to be off it for a little while, which might just not be acceptable in terms of symptom management. So that's a very individual thing. But just be aware that, yes, I think we've so far only seen 1 or 2 cases where patients were on binders and ran the StoolOMX. And it does seem that it doesn't, if they're on it, obviously because they have bile acid malabsorption, on the bile acid part of the test, it still showed that they had bile acid malabsorption. So whether that means that their treatment wasn't as effective as it could be, we're not really sure. So I think it's mostly a way to look at, do you want to see their baseline before treatment and see then if treatment helps that situation? If they're already on treatment, if they're doing really well, there may not even be a reason to check because they're symptomatically doing great. But if they're still symptomatic, then you want to see what's going on. If you still see bile acid malabsorption, maybe that treatment's just not working very well. And again, you might want to work upstream and look at small intestinal health. Look at that dysbiosis, for example, consider biofilms, and then maybe you'll get a better response.
So if a practitioner patient decides, let's try and get off it, I guess as soon as the patient starts having the diarrhea, that's when you can start testing. But, what's your...
Yeah, I mean, you can test. So patients that have diarrhea, generally, unless it's really severe and watery diarrhea, that can affect the results. Some things might be below the detection limit if they're too diluted. But generally, because everything is normalized to the amount of stool that's added, the weight, that basically doesn't affect the results much. So I think again, we don't have any specific guidelines on whether they should be stopped or not. So I would say it really has to do with the practitioner and the patient's decision about what do you want to understand, what do you want to know. Do you want to know how bad it is while they're off of it to get a sense for what's their need for this, and then if they're on it, is it effective?
A question could also be a little bit like, what about if they are on fibers as well? And so there's many, so maybe it's more like, let's just test. But what we could do, I was thinking, if any of you practitioners out there who's doing a test with someone who's on Cistran, you could maybe let us know and we can let you guys know, and maybe we can build some, we're all in this together. So the more we as practitioners feedback to the labs as well, we can create some guidelines. So maybe that could be a way of us getting to get more data and gather more details. Can you comment if patients are on butyrate and ox bile? Those could be supplements that people are taking. And you may just say, we don't know. That's fair enough. Then we will find out maybe.
That is true that we don't really know yet, although it depends. When it comes to butyrate, it would certainly depend to some extent on, obviously what their baseline is. I mean, I'm always in favor of, if possible, do a baseline before treatment, so you kind of know. I mean, that's obviously usually what's prompting treatment, is knowing what that baseline is. But that way you kind of know, are they coming from a really deficient standpoint or just a little bit deficient? But the form of butyrate does make a difference. So there are some forms that are more targeted to the colon and more likely to register on the test. So with tributyrin, for example, that's a form that is known to reach the colon in higher amounts. And so likely that would result, if you're taking a lot of it, in, of course, seeing elevated levels on the test, or at least normal levels if they started off deficient. So you do definitely want to know those things and take them into account. Other forms of butyrate might be more absorbed in the small intestine and might not have as much of an effect. Fiber is really complex. We actually had we have some resources on the different types of fiber. And again, if we can work with you to access those resources potentially if you'd like. But the story of fiber is very complicated. There's different types of fibers, different solubility, different properties. Some are recommended for constipation. Some are recommended for diarrhea, etc. And so it would depend on the type of fiber that they're on. And there's really not enough research so much on most of those fibers and how they affect bile acids. There's only some that are known to bind bile acids. Those are usually not so much the soluble ones or the oligosaccharides. Those are things like psyllium, things that have some cellulose in them, etc. But some of the soluble fibers can bind bile. So it's a little bit of a complex topic to say which fibers, have which effects. There's not that much.
Well done for giving it a go. At least.
Complicated.
So when you read the vitamin K study as biofilm buster or preventer, was it K1 or K2, or did they differentiate it between it, or?
It was K1. Yeah, so, and that's. Oh, go ahead. Sorry.
No, it was just to say that we had what's his name? Dr. Pimento. We had him on a webinar in regards to SIBO testing. I don't know, maybe a year ago, maybe not, maybe a little less. But he was just the next day, he was going to present on a study they had done using NAC in regards to treating SIBO. And he was going to say that everybody, when you're working with dysbiosis and SIBO, for sure, but they were using NAC. And that was, I think, 500 milligrams 3 times a day. It's in the web. It's in a webinar that's recorded on BMS. But it's just to support what you're coming up with here, how biofilm is actually really important, and it's a big thing when treating also Lyme's disease. How Lyme is lying in biofilm in the blood, and how biofilm breakers, how important that's very often like serrapeptase, I think they're using for that. So it's just to underline what you're also bringing up there as a clinical pearl for us to be aware. Why are SIBO or dysbiosis patients difficult sometimes to treat? Maybe it's because something is going on in the or there's a biofilm that's covering the bacteria, and we can't actually, with all our tools like antimicrobials, etc., get close enough to the bacteria to actually kill it or eliminate it, or
Exactly.
So let me just see what else I had. Lots of things. There were quite a few questions that I didn't really understand per se. So I've just tried to gather at least some of those that were like relevant for the questions here. But a lot of people have said thank you for the talk, and I thank you as well. And all of you reach out to us if you have questions, and our clinical support team can help you, and we can reach out to the lab and get further questions, and then let's work together on making this a great product so that we can gather data. So, but we will send out the recording, we will send out the slides that we will hopefully get as well. And we will send out the interpretation guide for the OMX add-ons for sure, so that you have that as well. And otherwise you find supportive material under the actual test in VMS. So one question just came up, and I think it was Hannah Sa, or one of the Danish practitioners, I could just recall the name. So one question was more like, and this is a good question for in general, like, should people stop taking like all kinds of supplements before they do a stool test, or should they just be on it? I can say what I generally do. I say, if a patient, if we want quick answers, just do the collection as quickly as possible and we get answers. Otherwise, we might have to wait 2 weeks until we can do a collection. If there are supplements and medications that a patient can't be without, I certainly don't want to take that away from them so that they have to suffer because we have to do a stool test. Then we are dealing with pattern recognitions. We are also dealing with knowledge. And then what happens when we are acting on the knowledge and we are maybe giving a supplement, or we are moving foods from the diet, or we are adding foods to the diet, or we are beginning to stand on our heads more during the day, or whatever, meditate, or whatever it can be. So that's my take on it. But what do you say, Tom?
Yeah, I think my perspective is similar. And again, DSL doesn't really recommend avoiding anything in particular except things that are really well known to disrupt the microbiome. For example, antibiotics. There's a strong recommendation to basically wait about 30 to 60 days after the end of a treatment like that. And that would apply generally to antimicrobial herbal protocols as well. Things that you know for sure are going to disrupt the microbiome and skew the results in a way that are going to confound what you're looking for. But it's very common for when patients are on a particular regimen to run the stool test. Don't tell them to stop their regimen, because you want to know, how is that regimen working, right? And it's usually in the context, as always, if patients are doing really well in their regimen and they don't have any significant symptoms, why run a stool test? That's an extra cost if they're already doing well, unless you just really want to have the data. Usually it's if they're still symptomatic in some way and you want to see what's still a problem. So, other than the major disruptors like antibiotics and herbal protocols, there really aren't any significant recommendations officially what to do. And I always like the idea of a baseline if possible. I mean, that's not always possible, but if you can get a baseline to see where are they starting from and then see how the treatment is affecting it, that's sort of the ideal scenario. In the real world, that doesn't happen very often. So you just work with the information that you have, and you do take into account everything: lifestyle, diet, supplements, etc.
So I guess if we resume next year, which we will, I hope, then yeah, maybe there's some more patterns in regards to what it looks like, and so more based on what you actually see in the lab rather than the research out there. So, and that's all you out there helping to do clinical work and asking the questions so that this information can get gathered as well.
Yeah, we learn a lot from practitioners, so definitely feel free to pass any information along that you'd like.
Sounds good. So all of you out there, I hope to see you on the 22nd of May. That's in 7 days in regards to hair mineral testing. I'll be there, that's for sure. And I hope to see you, some of you there as well. Have a lovely day, evening, and take care. Reach out if you have any questions. And thanks to you, Tom.
Thanks so much, and Catherine, and thanks everyone for listening today.
Bye.
Bye-bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.